moved him around.
You moved him around? Okay.
Tom Davis, how you doing?
Oh, hi, how are you?
Good, very good.
I heard you had a
Hello, John George.
What's that?
You were in Detroit.
Yep, I was in Detroit yesterday.
Yeah.
We met
Thank you for
last
coming.
year.
We're waiting for Steve.
Yeah.
Well, this is, we had to make it a little closer. But we're missing one person, so it should work. What's going on, guys?
Flip it on the screen resolution.
Are we, what happened? What happened? Did somebody step on the cord? Uh-huh. Oh. Oh. Okay.
Probably going to be an advanced setting.
Yeah, we'll just start with, right, to get everybody cute, and then I'll make just a couple of comments. Right, and then we'll start, yeah. Right. Okay.
Yeah, screen resolution. You go to screen resolution and switch it to.
Here comes Carolyn.
Portrait flipped.
All right, you got to flip that.
Yeah, flip it.
Hang on. Now the mouse is all weird.
I haven't seen Steve. He wants her to step or something. Question and answer.
This is so strange.
There's something.
Yeah, that should be fine.
He's gonna try to help. Would he be willing to help? I've been learning to be. I think he'd be perfect. He's such a good
Alright,
teacher.
you got 5 seconds.
Okay. Well, maybe we can get Steve.
Just hit enter.
Because they have such a good setup there. Okay. Steve, hi. Good morning.
We're doing mostly great.
We're good? It's okay? Good morning. And welcome back to the second day of the Venous sessions. Everybody now has a little bit of adrenaline surge from that music. And we have a powerful committee or group here today, a panel on the podium with some very good talks. And I just want to remind everybody who needs to sign in for their CME credits to do so, RTs and nursing. And also if you haven't registered for the Fellows Workshop on Saturday, please do so for the pedal, arterial, and venous anatomy sessions, and of course the other carotid session. So with that, I'm going to introduce Dr. Ron Bush, who's our moderator for this morning, and we'll get started. We had just a little problem with the computer, as you know, and thank you for your understanding.
Thank you, Patty. We're going to have to start off with our first speaker, who'll be Dr. Komar. We had a change in our program. And he's going to be talking about the management of obstruction and venous reflux in deep veins.
Thank you, Dr. Bush. And actual speaker was Dr. Tripathi, who couldn't make it from India. So if you don't like some of these slides, just don't kill the messengers. So the deal here is, this is the talk I got from him, contemporary management of obstruction, venous reflux, and deep veins for venous leg ulcers. Now, all of you know that there are superficial venous system and deep venous system. And majority of time, we do talk about superficial incompetence and superficial reflux. But as you embark on this venous practice, you will come in your practice that you will begin to see cases such as this. Leg ulcers just above the ankle, and majority of these patients are chronic venous ulcerations who have sought help from their family doctor, internal medicine doctor, regular doctor, wound care center, and then eventually come to you. So the data says 3 to 11% of adult population have got this category 3 to 5 chronic venous insufficiency. And 18 to 13% of population, 0.18 to 1.3% of adult population has C6, that means very difficult chronic non-healing ulcers. Now, a common way of treating this problem is utilizing mostly the compression therapy. However, compression therapy is not very helpful till the anatomical variant is corrected. So Raju and their group basically looked at the deep venous incompetence, and they identified that 3 major problems do occur in venous system. One is incompetence of deep valves. Second, rhythmic changes because of the respiration and long hours of standing. And surgery, if just done for superficial veins, is usually not sufficient. And these are the images in respiration utilizing ultrasound technology to show exactly how the valves move. Now, C5 and C6, in my practice, I've seen significant number of these patients come in because the wound care center tend not to recognize the issues, and they continue to debride and treat these ulcers without realizing exactly the deep pathology behind it. So they tried using the usual therapy of compression, wound care, etc., and you can see after 10 years, these people continue to have these kinds of ulcers. So basic pathology behind it is deep venous incompetence. Narayan Hudrale is a vascular institute in India where they actually looked at these number of 375 patients over a 5-year period. And documented DVT history was only seen in 15%, and then they evaluated 393 limbs for deep venous incompetence. Interestingly, 73% of limbs have problem with iliac veins as well as inferior vena cava. What they did was they basically brought these patients in and did the CTV with color flow dynamics. And as you can see in this image right here, where the arrows are pointing, what they call it target sign, you can see the narrowing in the size of the vein as compared to the opposite sides, as you can see in this image. And then they also looked at presence of pubic collaterals, indicative that iliac vein is occluded somewhere or the other. And then in real cases where the iliac vein is totally stenosed or occluded, can be easily seen utilizing a venous CT. So they identified isolated iliac vein obstruction in 257 limbs and combined disease, inferior vena cava and iliac, in 32 limbs. All these patients basically underwent iliac and inferior vena cava stenting, and with 92% success rate. And they have failure to cross lesions, especially in iliocaval lesions in about 12% of cases, which is pretty high. And lymph with isolated occlusion, they have trouble crossing about 8% of cases. And this is a very busy slide, but what this slide shows that initial patency of these stents are about 96 to 97%. And as you follow beyond 3 months to 24 months, you can actually see the patency declines to about 71%. However, the interesting part in the lower left side, if you see, the freedom for ulceration continues to remain same, actually rises. 73% in 6 months, and at 24-month interval, they saw 78.9% of these patients will continue to have healing process combined with compression therapy. So these are the kind of post-thrombotic syndrome lesions we can actually see. You can see in the picture inferior vena cava has big thrombus load, and the left side on the iliac vein is more or less occluded with those large prepubic collaterals which we have seen as CTV. These veins actually produce significant amount of issue because of crossing. Large collaterals, veins cause a lot of difficulty in crossing these wires because wires have a tendency of going into the collaterals, which are actually very tortuous. And you have to make a significant amount of work to get through these veins. And here is an example where vein lumen is very small and streaky. You can see the contrast flowing around the thrombus, vein filling, inferior vena cava filling very, very slow, and large number of collaterals around. And when you try to put the wire through these areas, you will basically find the wires trying to go into collateral or space around the thrombus. And it's very difficult to track these wires into inferior vena cava, which is a very tedious process. So here's an example. Can we play that video on that side? I had that trouble. But actually, you can see large collaterals on the image and the wire actually going through the proper vein, which took them a very long time to cross through. And as you can see, large number of collaterals in the run image, and then these collaterals actually prevent that wire has tremendous difficulty going through. And then once you're able to cross the lesion, initially dilatation is performed with small balloons. Do not go for large balloons because there is a tendency of rupture of these veins. So you can gradually begin to dilate. They started with like 5 millimeter balloon and continue to dilate up to 9 or 10 millimeter depending on the size of the iliac veins. And key is to establish a very good flow. In the last case, as you saw, there was tremendous amount of difficulty crossing this lesion, but finally lesion got crossed, and it stented all the way up to the inferior vena cava to establish the flow. The important part is inflow also must be checked in these patients, and oftentimes the problem is into the common femoral or superficial femoral vein because they were previously thrombosed. So if there is no inflow, the stents in the iliac vein tend to occlude sooner compared to people who have got good inflow. So in this case, actually, they are going to put the stents in the femoral vein, extending all the way up to superficial femoral vein. And as you can see, the images have to be taken with hip flexion to identify whether the stents are overlapping nicely or they are kinking. Risk factor for stent occlusion is often inadequate anticoagulation. There is no general consensus exactly how to treat them. Oftentimes, these patients are treated with Coumadin therapy or warfarin therapy, but in some cases, they have been and we have been successful utilizing antiplatelet therapy alone. Poor inflow at the time of index procedure, as I mentioned before, is responsible for these stent occlusion and thrombosis in future. And then these stents must be overlapped. You must realize the iliac veins are 10 to 12 millimeters in diameter, sometimes even larger. And if you put the stents overlap, which is shorter, stents have a tendency to come apart. And then all these patients must be purely evaluated for thrombotic disease patterns, anti-thrombophilic thromboplastin 3 deficiency, etc. So access-wise, when we are treating these patients, it's important to access either popliteal vein, you can do short saphenous vein, or you can have a direct puncture of the common femoral vein, and then able to turn the angle to identify the area at the femoral vein so that the balloon angioplasty and stents can be performed. Here is an example of 90-degree hip flexion where these stents are nicely overlapped and actually following nicely into the common femoral vein without any angulation. And similarly, this slide basically emphasizes the importance of overlapping the stents as well as getting the inflow. So oftentimes the question is raised whether common femoral vein or superficial femoral vein should be stented or not. But the point I'm trying to make here is if the inflow is poor, the outflow is not going to work. So in conclusion, deep venous obstruction of valve reflux should be thoroughly investigated. Iliac vein stenting results are good, but long-term stent patency must be maintained. Thank you.
Thank you very much. Our second speaker, is there any, I guess we have a couple of minutes for questions. All right. Thank you, Dr. Comer. Our next topic, Dr. Jarson will talk on treatment of superficial and deep reflux below the knee.
Thank you very much. I have no disclosures. I was asked to speak on the topic of below the knee reflux and treatment for this entity. I will not go through these numbers. They are, those are numbers that you are all familiar with, but just impress upon you the importance of the venous disease in the total health of the population. Now, what are the veins that we are dealing with below the knee? My main topic is going to be the greater saphenous vein and the management of that below the knee. I will also touch on the small saphenous vein, the perforators, but I will leave the deep veins alone. Now, there are many treatment options, and I've elected to only talk about endovascular thermal ablation. I personally do not participate in the use of venoactive drugs, open venous surgery except for phlebectomies, but my main focus is on treating larger veins with endovenous thermal ablation. If it first talk briefly about the perforators, obviously an important part of the circulation connects the deep and the superficial venous system. The medial ones are felt to be the most important ones when it comes to symptoms of incompetence. And these images here are just to refresh your memory on the locations of those. The most important ones are felt to be the medial ones connecting to the deep or the posterior tibial vein, and then the peritibial perforators, which also communicate with the posterior tibial vein. But we have a multitude of other collaterals, not only below the knee, but also in the thigh area. Now, in 2011, the Society of Vascular Surgery and the American Venous Forum came out with a document published in the Journal of Vascular Surgery giving clinical practice guidelines for the management of venous reflux. And as far as perforator goes, they set up quite stringent definitions of what was a pathological perforator using reversed flow direction time and also the diameter of the perforator at the fascial level. And also commented on the fact that these should, or commented on that there was not enough evidence to support treatment of incompetent perforators except in the situation of a wound or a healed wound, so C5 and C6. As a weak recommendation, graded number 2, and based on an intermediate level of supporting studies. This is just to go through one study, a study that came from the University of California in Los Angeles, 45 patients, 75 ulcers that did not heal over a long period of time, and all of them were treated with endovascular heat ablation. They had a 60% or less than 60% initial success rate if you look at the ultrasound evaluation. Additional ablation was performed in 12% of the cases. About 90% of the ulcers healed, and they found that none of the patients healed if they did not occlude at least one of the perforators. They had no complications in this series. They also looked at how the individual surgeon, that is the left image, how his performance improved with time. And you can see that there was a significant improvement in the ability of being able to occlude perforators as time and experience proceeded. And on your right side, you will see a slide depicting the whole group of participating physicians. So just to make the point that this is something that you really have to do frequently in order to be good at it. So the conclusion of that we do not have really good evidence to support treatment of perforator veins unless we have ulcers, and you should probably adhere to the criteria that are set forward forth in the recommendations. Now, that doesn't say that we will not in the future have evidence to support treatment of these veins with other situations, as we heard about yesterday and probably will hear about today. Small saphenous vein, I think most of us are treating this vein just like the greater saphenous vein. Some centers recommend puncture above the mid-calf to avoid thermal damage to the sural nerve. And the outcomes are generally similar to what we expect from the greater saphenous vein. Just a brief overview of one article, 150 patients, just under 170 legs. These are the ages, and you note that 90% of the patients were in class 2, 3, and 4 in the using the sheep classification. %8 of them were occluded on follow-up ultrasound, and they had a 1.3% paresthesia, which is quite comparable to what we would expect from the greater saphenous vein. So the greater saphenous vein below the knee, the recommendations from the same article as I talked about is that it should be treated with thermal ablation or stripping above the knee. Now this mainly becomes, this recommendation, that is the fact that they recommended it to be treated above the knee, really becomes or is based on the fact that trauma to the saphenous nerve is increased if you treat them below the knee. And this is based on previous papers. For the stripping procedure, about 40% incidence of paresthesia, and if you look at the endovenous ablations, you're talking about a frequency of 8 to 13%. But you also know that if you treat an incompetent greater saphenous vein from the knee up, you have a significant number of below the knee remaining vein that will become more and more symptomatic and incompetent with time. Just to depict the relationship between the saphenous nerve and the greater saphenous vein here. You can see that on the left side of this image here. 59 patients treated here. This is from Switzerland and the Netherlands. All of them treated from below the knee. And I want to draw your attention to the line below the lower blue row there, which demonstrates that the reflux over time at 6 months and at 2 years increases in the segment that was left alone. So this was ablation above the knee, which goes to demonstrate just the simple fact that I mentioned before, that if you leave an incompetent or a competent segment below the knee, there is a significant amount of these patients that will develop reflux in that segment over time. And they, in the same paper, referred to 3 other studies that just demonstrated the same fact. This is a separate paper looking at the 50 ablations below the knee, demonstrating an 8% incidence of paresthesia. Now this really prompted one of my colleagues in vascular surgery at Mayo to look at her outcomes treating greater saphenous vein below the knee. This is a typical patient with reflux down to the ankle level, and another patient with similar extents of incompetence. So the aim was really to look at what happens to these patients that are treated with endovascular ablation, heat ablation from the ankle or at least the calf area all the way up to the saphenofemoral junction. 65 patients that had primary treatment, and then there were 14 patients that needed retreatment. Those are the basic informations about the patients. You can see that the SHEEP classification is about 3 to 4. And then there was a host of other veins, accessory greater saphenous vein, and incompetent perforators that were treated at the same time. They had complete success initially. They had no skin burns, and you can see in those that had only one treatment, there was a 0.5% paresthesia, but if you had to treat them twice, there was a significant increase in the number of paresthesias. So, as a conclusion, I think perforator ablations, at least if you look at the data that we have, should be reserved to patients that either have active wounds or preferably to those that have healed wounds to prevent reoccurrence of those. The small saphenous vein can be safely and effectively ablated, and I think we can look seriously at treating the greater saphenous vein from the ankle to the saphenofemoral junction without any significant consequences. Thank you.
Thank you very much. Are there any questions real quick? We have about a minute. I might just make one comment. In the Rivada study, if you start the ablation below the level of the Sherman's perforator, which is a peritibial, I think, I don't know, 4 or 12 now, you'll have less reoccurrence. And that's assuming that the saphenous vein is incompetent at that level, which a lot of times they are. Perforators to be treated, you also should consider treating perforators if they're the etiology of the varicosities you see, which they are many times. They're not purely reentry perforators, but they may be the pathology, which we'll talk about later. Small saphenous veins can be treated with equal results with foam sclerotherapy. And you get the same results, and it's proven in the literature, especially by Darvell's study in England. Our next presenter, Dr. Dean from Ohio State University, is going to talk on a favorite topic of mine, venous aneurysms.
Good morning. All right, I was asked to talk on venous aneurysms and no conflicts of interest. I was wondering, how could you have a conflict of interest treating venous aneurysms? I think that'd be difficult, to say the least. Let's go over the definition of venous aneurysms. Well, it's very controversial, and there is absolutely no definitive size criterion in the literature to distinguish between venous dilatation and venous aneurysm. That being said, by convention, most people would use 2 to 3 times the anterior-posterior diameter of the normal proximal segment to define an aneurysm. Now, If you want to be very busy and have a lot of nervous patients, anxious patients out there, use the 2 times AP diameter. I prefer the 3 times for the majority of my patients. And then there's also, just for the popliteal vein, if it's greater than 2 centimeters, an absolute diameter exceeding 2 centimeters to define an aneurysm. That obviously would be more than 3 times the normal diameter, since the normal popliteal vein is around 5 to 7 millimeters. From an epidemiologic standpoint, they're said to be rare. In fact, that's supported by a lepropulosis study looking at almost 4,000 patients where saccular popliteal vein aneurysms were identified in only 0.2% of patients. Now, the only exception would be from the superficial system, where great saphenous vein aneurysms were identified in 12% of patients in one study. From a gender standpoint, there tends to be equipoise when we're looking at all venous aneurysms, but when you look at specifically the popliteal vein aneurysms, they are more common in females. They could occur in any age. Distribution, the lower extremities are the most frequently affected site. As we've seen, the great saphenous vein will be the most common, followed by the popliteal vein, followed by the femoral vein, and then decreasing order of frequency, the abdominal veins, the head and neck veins, and the thoracic veins. I don't know how that one showed up there. Sorry, but anyway, the thoracic veins is the least likely. How do they appear? All venous aneurysms can be saccular, as represented by this venogram, or fusiform, as appearing here. What's the pathogenesis of a venous aneurysm? Well, really, it's actually unknown, but here are some of the purported mechanisms. It involves reflux and venous hypertension, inflammation, infection, a congenital vein wall weakness, some type of mechanical trauma, and you see repetitively in the literature localized degenerative change. And more than likely, it involves a combination of congenital and some of these acquired factors listed above. From a histological standpoint, when you read the articles on venous aneurysms, they repetitively quote Lev's 1952 article where they documented endophlebihypertrophy and endophlebiosclerosis. Also, increased expression of a select matrix metalloproteinases has been documented. And finally, Gabrielli and others have documented diminished smooth muscle and fragmented elastin fibers, which conceptually you could see where that would lead to venous dilatation. So let's start with the venous aneurysm of the jugular vein. Now, this is rare, and it's responsible for approximately 1 in 3 of all venous aneurysms, typically found in young adults and children. Most common in the internal jugular vein, followed by the external, followed by the internal jugular vein. Congenital jugular vein aneurysms tend to be fusiform in configuration. Acquired jugular aneurysms tend to be saccular. They're found on the right side when they're congenital, found on the left side when they're acquired. So on the right side of the screen here, there's a 12-year-old boy with a fusiform congenital aneurysm. And on the left side of the screen is a 48-year-old woman with an acquired saccular external jugular vein aneurysm. Also, some of the salient clinical characteristics, these typically present with a soft compressible mass that enlarges on Valsalva maneuver. Also encourage you to have your patient breath hold because these become much more prominent. The natural history is really unknown, but they tend to be quite benign. In fact, in all the literature, there's less than 200 cases. There's only 2 pulmonary emboli that have ever been reported. On to thoracic venous aneurysms. Again, very rare. Only about 60 cases have ever been reported. The majority involve the superior vena cava, or surprisingly, the azygous vein. And also surprising, there's a consistent association with superior vena cava aneurysms and cystic hygromas. These are usually large with an average diameter of 6 to 7 centimeters. They're often asymptomatic, like most venous aneurysms, and found incidentally during imaging studies. When they are symptomatic, they're associated with chest pain and aneurysmia, and thromboembolic complications and aneurysm rupture are extremely rare events. Here's a radiographic representation of an SVC aneurysm with associated mediastinal widening. And here's a very rare innominate venous aneurysm, and I got to give the authors credit. This was published just last year. This was in an 84-year-old woman that came in with some vague chest pain, and it was found to have this right-sided, somewhat pericardial mass, and as you can see on the right side of the screen, they went in and biopsied this right-sided mass. Well, luckily the patient did okay, and they just showed necrotic material and came back 3 months later, and then they injected the contrast into the left arm and actually found this was in a left innominate vein aneurysm that was going across the midline, And fortunately, the patient did okay. You can see there's thrombus in the aneurysm. And what about visceral venous aneurysms? Any abdominal vein can be affected, but by far the most frequent visceral venous aneurysm is the portal vein aneurysm, by far. In decreasing order of frequency would be a splenic vein, superior mesenteric vein confluence venous aneurysm, followed by a splenic vein aneurysm, followed by a SMV aneurysm. Often you'll see a portal vein aneurysm defined as greater than 2 centimeters in diameter. Where do you typically see portal vein aneurysms? Well, in the setting of cirrhosis and portal venous hypertension. Like most venous aneurysms, portal vein aneurysms are usually asymptomatic. When they are symptomatic, they're associated with GI bleeding or abdominal pain. Here's a good image of a portal vein aneurysm. And finally, we're going to end here on popliteal venous aneurysms because these are the most frequently reported venous aneurysm and also the most controversial when it comes to management. Here's an example of a fusiform popliteal venous aneurysm. It makes up about 1/4 of these. And there's our saccular popliteal venous aneurysm represented ultrasonographically on the left. Now, most of these, like most venous aneurysms, are asymptomatic and incidentally identified via your duplex ultrasound. Now, if they are symptomatic, they tend to present in one of 2 fashions. Now, here's a good table here looking at a literature review as well as a author's series. This was Perrin's 2006 study. But you can see in the literature review in this one study, roughly half of these patients presented with a pulmonary embolus or a DVT. First of all, a very distinct minority, 5% or less, actually have a popliteal venous mass that you can palpate. And then in the author's series, as well as another larger series, which involved 25 patients, 75%, roughly 3 out of 4 of these patients, present with manifestations of chronic venous disease. That's when they're actually symptomatic. So bottom line, if they're actually symptomatic, they're going to present, not surprisingly, with either manifestations of venous thromboembolism or chronic venous insufficiency. And there's a good example of reflux in the popliteal vein occurring distal to an aneurysm. And there's an example of an unfortunate deep venous thrombosis within a saccular popliteal vein aneurysm. And then finally, this was just published a couple of months ago. There's a reference here, and I encourage you to get this pretty well-written article in the Journal of Vascular Surgery looking at treatment strategy for all venous aneurysms. So let me see if my point, gosh, touched somebody in the audience here. Treatment strategy for all venous aneurysms. So we'll start here. Is it a popliteal venous aneurysm? We'll come back to this. So let's say it's not. It's SVC, it's external jugular vein. You answer the following questions. Do they have thrombus? Are they symptomatic? If they're not, you simply use some type of surveillance protocol and follow them up over whatever period of time. The natural history is not well described. I would suggest you follow them at least on a yearly basis. Let's say they are symptomatic or they have associated venous thromboembolic disease. Well, then they need surgery. About the only other time you would consider surgery in these patients would be the patients for cosmetic standpoint, specifically the patient that has an external jugular or an internal jugular deep venous thrombosis. Because as you can imagine, most people don't want to walk around with this golf ball-sized protuberance in their neck. So those somebody would consider surgery on. But then finally, let's go back here to the popliteal vein. Now notice what it says here. Popliteal vein, yes. So they don't even define the size of the popliteal vein. They're saying that any popliteal venous aneurysm should go to surgery. So let's see if we can further refine that recommendation on a subsequent slide. Well, this is Vermeer's recommendation, surgery for all popliteal venous aneurysms. I don't know if that's necessarily realistic. Here's another recommendation made by 2 of the larger series, Sessa's 2000 study and Maladano-Fernandez study, which is also a very good study. They say all saccular popliteal vein aneurysms should be operated on, and then they say any fusiform aneurysm exceeding 2 centimeters should be operated on. And their justification is that neither the popliteal venous aneurysm diameter nor the configuration can be considered solid parameters to predict venous thromboembolism or venous insufficiency complication. And that's their rationale, because there are case reports of somebody with a 1.3 centimeter popliteal vein aneurysm coming in with a PE. or associated VTE. But I would submit to you the problem with that is a potential publication bias. What about all the other hundreds, thousands of patients out there that have none of these complications? Obviously, these were the 212 patients. That's all there are in the surgical literature that were actually reported. So I just don't know that it's realistic to say that these patients all need surgery. And then you may say, well, why don't we just anticoagulate them and prevent potentially the worst outcome, which is a PE? Well, here's the other problem. Recurrent pulmonary embolism with popliteal venous aneurysms, despite anticoagulation, has been documented in multiple case reports. Well, I pulled a lot of these case reports, and I'd say in about half of them, the true recurrence in the setting of anticoagulation was quite sketchy. They had subtherapeutic anticoagulation. The anticoagulation was stopped around the time of the procedure. A couple of patients had massive or submassive PEs, so I don't know about this. I mean, it may be a real issue, but I'm not convinced it is. And if you do surgery, this is the preferred surgery of choice. That's a tangential aneurysmectomy with lateral venorrhaphy. Venorrhaphy. I think I can say that. But anyway, that's what it looks like. So that, again, begets the question, based on a series of all that's out there, 212 patients in the surgical literature, when to operate on an asymptomatic popliteal vein aneurysm. And I don't know what the right answer is. I mean, Dr. Thorpe may say 2.5 centimeters, and she may be right. Dr. Rook, from this picture taken for him just last month, may say 4.25 centimeters, and he may be right. I queried 5 of our vascular surgeons at our institution, and I asked them, when would you operate on a popliteal venous aneurysm? All 5 of them said at 4 to 5 centimeters. And the surgeon with the most experience, the chief of our department, has been there for 29 years, said he's only operated on 1, and that was a 5-centimeter aneurysm in his 29 years of practice. Now, hopefully this movie is going to play. Please play. Don't think it's going to play. Why isn't it? Do I need to push something maybe? I don't know why this is supposed to automatically play, but it's not playing. Anyway, I was just going to show you an example of a. Oh, well, it's not going to work, I guess. But anyway, so in conclusion, I mean, and it's not a HIPAA violation. This is my popliteal vein, 1.4 centimeters. My normal diameter is 7 millimeters. So by definition, I have an aneurysm. There's no way I'm going to let anybody operate on me right now. I may die of a PE. You may never see me again. But so anyway, there's a lot unknown with popliteal venous aneurysms. And thanks for your attention.
Thank you very much. Are there any questions or comments? I just might make just a couple of comments to Dr. Dean's report. Pasquarelli's 12% GSV aneurysms were related to his definition of 1.5 times the size of the contiguous vein, which is totally wrong. Gabrielli goes at 3 times. We just recently submitted a paper that we propose that the definition be 2 times the size of the contiguous vein or 3 times the size of the normal vein diameter. These are in superficial venous aneurysms, which are more common than you might expect. In our series, are about 5% of all patients seen over a 2-year period. And we reported 6 cases of AAGSV aneurysm, 3 of which presented with spontaneous thrombosis. So they do occur, and they need to be recognized and treated.
Yeah, I think anyone that runs a vascular lab, you do see a lot of these in the superficial system, especially the GSV. It's not uncommon.
Can I ask one question, if you don't mind? Like for the cases or the patients here that you see, and anyone who actually develop PE or VTE, do they have any other venous comorbidity with those patients that may cause that?
Do they have any coexistent venous?
Like, for example, do they have like factor V Leiden or any other things?
Again, a lot of these are older case series, so they weren't necessarily tested. I'll say off the top of my hand, maybe a third of these. These are all case reports as a whole or case series. Some of them were checked for thrombophilia, and they did make a point in some of these studies of saying, no, there were no coexistent thrombophilia states in some of these.
Hi.
As another point, we've actually done histological studies of aneurysms and compared them to excised varicose veins. They're all the same. You can't tell the difference. If you put one beside the other one, you won't know which one's which, unless you can look at the distal vein. The question?
Yeah. So, I'm just graduating from fellowship. We used to do covered stent for the popliteal artery aneurysm, so that you can exclude the aneurysm. So is a similar thing can be done for the venous aneurysm, where you can exclude with like Viobond stent, which you can put it in the joints, and if it's excluded, does the aneurysm get smaller?
I've never seen it done. I have no idea. Has anybody ever seen that done? I never have.
The question, stenting popliteal? No,
Popliteal vein, yeah.
No, I don't think that'd be a good idea.
Thank you.
A question back there, Dr. Okay, guess we're going to go on and get the next presenter. Okay, now Dr. Gravopoulos is going to talk about optimizing wound post-intravenous treatment for venous ulcers.
Thank you. Good morning. Thanks for having me here. I'm going to switch gears a little bit, talk about venous leg ulcers, which, as I don't have to speak to this audience about how much of a pain they are, but actually I love treating venous leg ulcers. And more so now that we have developed all these wonderful ways to help them heal better. So let's go over a little bit of that. Some of these slides I'll kind of flip through kind of quickly because they're just redundant. But this is the type of things that I like to treat and that I treat in our clinic. I'm part-time at the VA here in Chicago, so we see the worst of the worst in that clinic. And I'll be talking in reference to some of those patients today. We know that venous leg ulcers are one of the most common ulcers out there that pretty much oftentimes go unnoticed or untreated because they're not diagnosed appropriately. So you all know that they're very common, they're out there, and they do account for most of the ulcerations that we see. The cost of treating these ulcers is absolutely staggering. The amount of money that is spent in treatment of these, both effectively and ineffectively, is a huge amount of the healthcare budget. We understand the pathology as to what's going on, but it's not always treated effectively because we don't do the surgery that we need to do. So let's talk about some of the causes of these ulcers and why they occur, what's going on with them. We know that there's venous hypertension there, perforators are involved, often venous insufficiency. There's clinical conditions that are causing the obstruction of the venous system. We know that perforators are often in combination with the superficial and the deep systems at fault, and therefore resulting in the venous leg ulcer. We know that superficial venous insufficiency is very common, although it doesn't cause a great deal of the ulcerations that we see. So typically when we see an ulcer, this isn't the first thing we think about, but it does have to be considered from time to time that is the cause. We usually see venous ulceration as a result of problems in the deep venous system and the perforator system. We know that this accounts for about 75% of all the ulcerations that we see. Of course, there's lots of risk factors for the development of these ulcers, including venous insufficiency that I already stated, obesity, immobility, phlebitis, deep vein thrombosis, and of course, family history. The immobility is interesting because with increased immobility, we have calf pump failure, and therefore the blood doesn't flow appropriately and they begin to ulcerate. There's some comorbidities associated with venous leg ulcers that we see often, including anemia, asthma, cellulitis, depression, diabetes, leg edema, hypertension, osteoarthritis, pneumonia, and UTIs, interestingly enough. There may be an onset of VLUs after some of these things that occur with the patient. A newly diagnosed diabetic patient is all of a sudden more suspect to get a venous leg ulcer. Those patients with RA all of a sudden should be screened for venous leg ulcers or venous insufficiencies. Of course, those with a history of hip surgery, we know that already, and of course, previous surgery or ligation therapy. So what does the data tell us? Of course, as I stated previously, the data tells us the VULs are the most prevalent type of chronic ulcer in the country. Even when there's structured guidelines by various organizations, for some reason these guidelines are not always followed, probably because many of the venous ulcers that are seen by physicians that don't even read those guidelines. They don't even get those guidelines. I'm talking primarily family practice, internal medicine physicians that typically aren't really, that's not their mainstay, and so they probably just tell the patient oftentimes, and I've seen this happen time and time again, just keep putting that ACE bandage on there, put this salve on there that I'm giving you, which we all know what that white salve is, God forbid, and it'll be fine. It'll go away eventually. And so they just languish for months and years. So why do some of these wounds become chronic? Why do they become non-healing? Of course, there's all sorts of things going on. Once that wound becomes apparent, it becomes ischemic, bacteria contamination, not necessarily to the point of infection, but just contaminated, slowing down the healing process, leading to chronic inflammation. Proteases, therefore, in this wound then become elevated. The fibroblasts, which are designed to heal the wound and build collagen in the wound, become senescent and decrease in their proliferation, and so the wound, therefore, is stuck in the inflammatory phase and cannot move out of this phase without some help. What we see in the inflammatory phase is an increased production of MMPs, and not the good MMPs, because there are good ones. We see the tissue-destructive MMPs increasing. The growth factors, which are usually stimulated by the fibroblasts, become ineffective because the coupling mechanisms of the cytokines fail to mature, and therefore growth factors become inconsequential to the healing phase. This results in the inflammatory process continuing into infinity if not treated. If we can move that patient from the inflammatory process into the proliferation phase of wound healing, we still have some hurdles that we have to clear, because now in this chronic wound, we have to respond to the decreased angiogenesis present. The growth factors that have been neutralized need to be reinstated. We need to find a way to increase fibroblast function and get rid of those MMPs. When we finally get out of that phase, the next hurdle that we have to clear in making sure this chronic wound heals is, again, to get to the remodeling phase and make sure that the wound tensile strength is appropriate to ensure reoccurrence not occurring, and increase collagen production to make sure that that wound heals in appropriate fashion. So we have to control that wound. And how do we control that wound? Well, of course, debridement. And we all know that debridement is certainly a lot easier in the diabetic foot ulcer because most of these patients are neuropathic. The venous leg ulcer, that isn't always the case. So debridement means they typically have to go under anesthesia or some form of local anesthesia in order to sustain adequate debridement of this wound. Pressure relief, wound management, management of the infection, if indeed there is infection present, and of course, management of the vascular problems, either medically or surgically. Typically, surgically is what saves the day. The successful management of venous ulcers requires understanding and treatment of the underlying venous disease as well as the aggressive treatment of the ulcer. I tend to be pretty aggressive in my ulcer treatment, so one of the first things that I do when I see a venous leg ulcer is make sure that they get Dopplers, venous Dopplers, and they go see the vascular folks to make sure that if any plumbing needs to be done, that gets done immediately. Now, we know that the current treatment of VULs, we understand this pretty well, and it goes along with compression, debridement, dressings, things like that, but it isn't always enough. It isn't always enough. This is some other treatments that we see, and surprisingly, we have a likelihood in this country of putting a silver dressing on a venous leg ulcer, even though in a Cochrane study in 2010 showed that silver really isn't effective. It's cadexamer iodine that is one of the most effective anti-infectives for venous leg ulcer. Understanding also that systemic antibiotics typically aren't needed in a venous leg ulcer because they're not systemically infected. They're probably contaminated. And that's why something as simple as condexamide iodine can do the trick in helping to control the antimicrobial or the bacteria on that wound. So compression has been there for a long time. There's different types of compression available. This is a new device that we've been using lately, the ActiTouch, which has improved patient compliance greatly because it's a little bit more comfortable to wear. Of course, some patients don't understand how to use it, so there's a little learning curve involved with that, but this seems to work pretty well. The at-home mechanical pumps work extremely well as long as the patients are compliant enough to use them. And there's different types of those. Nutrition and range of motion. I mentioned earlier that nutrition plays an important role in this, but also range of motion. Because the calf pump in many of these patients is not worked appropriately, either because they can no longer walk due to edema, obesity, discomfort, we've lost the ability of the calf pump to move that blood around. We find that sending these patients to physical therapy, oddly enough, is greatly effective in helping them heal. And if you told me that a few years ago, I would have told you were nuts, but indeed, it does work wonders. Sending these patients to physical therapy increases their range of motion, increases their comfort level in moving around, and strengthens the calf pump to aid in healing. So invasive management of venous disease, I probably don't need to spend too much time on that with this audience, but we know exactly how important this is in taking care of those underlying factors. We know that when invasive measures occur, we have an increased healing rate without exception. This works all the time. So combination therapy of invasive healing, invasive treatment, as well as topical therapies seems to be the winning combination. And there's guidelines by the Wound Healing Society for topical treatment of venous leg ulcers that include a variety of methodologies. Once we're able to get the underlying cause of the venous leg ulcer taken care of, we then go to some wound healing properties. And to go over those very quickly, we look at 4-week predictors. We like to have that venous leg ulcer closed by 40 to 50% within 4 weeks using a single therapy. If that therapy does not allow us to close that wound in that appropriate amount of time, we move on to a different topical therapy. Growth factors are very important. I mentioned earlier how growth factors are lacking in a chronic venous leg ulcer. We like to add growth factors to a wound. We have found that to be extremely effective. These are some of the growth factors that need to be part of the wound healing paradigm, and so we add those growth factors through a few different mechanisms. Apligraf is a product that was approved by the FDA in the late 90s specifically for venous leg ulcers and has been crucial to our healing rates in getting those venous leg ulcers to heal appropriately. It delivers fibroblasts and keratinocytes to that wound bed. The healing rate in this study with just simple compression with and without Apligraf shows approximately a 60% increase in wound healing using a product like Apligraf or using growth factors. Lately, in the past year or two, we've begun to use amniotic membrane wound care dressings that work just as well. These deliver the same types of growth factors to that wound. Sorry for the small type, but amniotic membranes have been around for a very long time in wound care. They've been used in burn patients for years and years and years. They've been used in eye therapy and eye surgery for a very long time, and now have come to the wound care marketplace, and we found them to be very effective in delivering the cytokines and the growth factors that should be present in normal healing skin to the chronic venous leg ulcer. EpiFix is one of those amniotic membranes. We've actually done a study with EpiFix. Dr. Serena's done a study with that, with venous leg ulcers, and found it to be extremely effective in healing ulcers. We've done some studies in our clinic using injectable amniotic membrane around the wound margin to stimulate edge effect wound healing, showing about an 80 to 90% closure rate within 10 days, which is phenomenal for venous leg ulcers. So these are some preliminary results from Dr. Serena's study showing that patients using the amniotic membrane are going to heal significantly faster than those who don't use it. The 4-week model, as I mentioned earlier, is our mainstay for treating chronic wounds. And if anybody were to say that those things are very expensive and we shouldn't be using them, there are plenty of articles out there to refute the fact that if we don't get these wounds closed quickly, they're going to linger and cost more money in the long run than the cost of the therapy that we're providing. So there's plenty of economic articles stating that advanced wound care products such as these and advanced therapies that we're using on these wounds make good economic sense in getting these wounds closed as quickly as possible, because we understand that venous leg ulcers typically are not going to cause these patients to lose their legs as a diabetic foot ulcer might, but it sure has an impact on the quality of life. And that's what we're talking about here, is quality of life in our patients. A couple quick little case studies. This is a venous leg ulcer using Apligraf in 3 applications. Over the course of a month, we got that healed. This is a chronic VUL, a 62-year-old patient, very non-compliant. You can see all the scarring, fibrotic tissue around. This is using an amniotic membrane called EpiFix, and we were able to get that closed in just a few weeks. And of course, he had a contralateral wound also that we closed quickly. And that's all I have for you today. Thanks so much.
Thank you. I'm going to present the next topic. Dr. Cabal wants to make a comment while I go to the podium. We're running a little bit behind.
So I just wanted to make a quick comment. I think that looking at this data and what I've looked at during the years, I think that venous ulceration are primarily ischemia, and there are many things that go with it. You know, that arterial inflow, it's affected with venous hypertension. There's superficial shunting. There's increased intake by cellularity in the area, and there's also a combination that people with a lot of edema have incompetent lymphatics. So I think that it's very important to understand that unless we treat all those things that he was saying, that we cannot heal these wounds properly.
Thank you. Next topic, please. Okay, I was asked to discuss the most contemporary treatment algorithm for 2014. I must say a lot of this is based on my experience. I've been doing nothing but venous surgery for 20 years. I used to do ASDs, VSDs, valves, bypasses, aneurysms, et cetera. 20 years ago, I walked out of the operating room and started veins. So this is my experience. And so the best treatment varies depending on the condition that is treated. Superficial varices alone is the most common class you see that you will see in your clinic. About 85% of the patients have C2 disease. We'll give an example of treatment protocols in the following cases. First, you must identify the source. The source may be the GSV, SSV, AAGSV, perforators, vena Giacomini, or neovascularity. That's the most common origins for varicosities. All varices have an origin and are usually the result of transmitted deeper pressure, either from the perforators or superficial valvular insufficiency. All varices are one branch. By ultrasound, you trace the first visible varice to the point of origin. Assuming that the GSV is the etiology, then you either treat with thermal ablation, foam sclerotherapy, or MOCA. As we showed yesterday, it makes absolutely no difference what modality you use, they're all the same. The same is also true for the SSV and the AAGSV. An exit phlebectomy is very important to do. This assures unloading of the blood in the variceal branch segment. So what you do is you actually do a varice, you don't tie it off, you do an avulsion. This actually can drain the blood retrograde into the tissue. There's not a lot of blood. And it can also re-entry. At the re-entry point of the varices will either be in a perforator or the GSV or the posterior branch, usually, of the saphenous vein. All varices, as mentioned before, have an exit and re-entry point. You must identify them. You can't rely on a RVT to do your work. When you see the patient before you do surgery, you should actually scan that patient, determine where it is so you can perform a proper operation. If you just go in there and do an intravenous ablation, you're not doing anything. If you go in there and just do a phlebectomy, you may or may not do anything. You have to know where the origin of the varices are and where they reconnect. There may be one or two branches. There's usually one branch in the calf. There may be a branch also in the thigh. A varicosity is simply a dilatation at a valve. There's multiple valves in the superficial branches. Every bump you see is a valve. That's all a varicosity is. The veins in between the bumps, the varices, are completely normal histologically. You can't tell them the difference between a normal vein and a varicose vein except at the valve. This way, talk about ambulatory phlebectomies versus foam. You can use what we do. We recommend ambulatory phlebectomy because it's a better procedure cosmetically. You can get rid of the blood volume much quicker. As you can see right here, this is the greater saphenous vein right here coming off. You can see the branch, a large branch coming off. This is what we would call the exit branch, okay? This is a branch, the first bump you see must be removed. It's very simple to do. Small incision, small hook, and avulse it. Do it under tumescent. This is what it looks like. You can see this is the exit phlebectomy we're doing right here. Whoop, sorry, go back. This is the exit phlebectomy right here. You can see we're pulling this vein out. This is the first branch after we've done intravenous ablation. As mentioned before, we usually start intravenous ablations below the level of Sherman's perforator or the second peritibial perforator if the veins dilate at that region. If it's not, based on the results of our Rivada study, you will have a reoccurrence. So do the right thing first. This shows you the valve that's present. All varicosities, as mentioned before, are a valve. And this is, if you do multiple phlebectomies of a branch, it's going to tear off. That's why you that's why you very rarely ever get a long segment of vein out when you do phlebectomies. Because it's very weak right here at the valve, it'll tear. No big deal. Just go down, get the next one, bring it up. In fact, if we're doing extensive phlebectomies, some patients don't want to come back and be reevaluated. They want to get it all done at one time. We do we mark every bump and then do every other phlebectomy of that bump. So that gets rid of most all of them because it tears off in the valve proximally and distally. So assuming that the source is neovascularity, which is very common nowadays after the standard flush ligations of the saphenous vein, you don't get that when you do non-flush ligations, but you do when you get flush ligations. You also get sometimes after doing thermal ablations. It's usually not in the groin, and based on the results of our Rivada study, most of these neovascularities occur about 4 to 5 inches below the groin after thermal ablation. But neovascularity is simply a group of small varicosities in the saphenous sheath. They may be secondary probably to inflammatory response. The treatment for this is to give foam sclerotherapy, usually 1%. This can be done directly, or it can be done through the first branch of the varicosity. Also based on unpublished data that we have, and we're still doing it, that foam sclerotherapy is inactive and non-effective 15 centimeters above the point of injection. That means that the endothelial cells are still present 15 centimeters above where you injected in one branch. So if you stay close to the origin, the first branch, you'll probably get into the neovascularity and get good penetration. If you try to do it down further, it's not going to work. Or you can do ultrasound guided directly. This is what a patient looks like that has neovascularity. This is from the groin. You can see multiple little varicosities. This is what it looks like on the ultrasound. You can see these multiple varicosities in here. This is the femoral vein down here. In this patient, we're actually injecting the first visible varice with a butterfly needle, 3 cc's of 1% foam. You can see now that the foam is in the varicosities here, the small varicosities. We've actually done over 300 of these patients and had absolutely no DVT, which you would expect because foam's rapidly deactivated. But here's another little trick sometimes to prevent foam, if you're really worried about foam getting into the femoral vein, which it always does, but try to keep it if you can keep it in contact for the first 15, 20 seconds, then there will be no activity of foam at all, just bubbles. But sometimes we do this little technique. This is under ultrasound guidance. We're injecting tumescent solution. You can see now that the tumescent solution is compressed, all the foam injected right here, okay? And the next slide shows you, here's the compression, there's no foam in the femoral vein because the patient's lying still, okay? And then when they get up and walk around, so what? Bubbles go in there, big deal. They don't have any sotrodecolon, they're not going to cause anything unless you have a PFO, and you may have a neurological problem, but that's very rare too. Assuming the perforator is the etiology of the varices, we foam the perforator. Usually 1% is adequate if they're anticoagulated, 3%, and then we do a phlebectomy. You can also foam the varicoses, however, it's not as good as doing a phlebectomy. So we usually do a phlebectomy in combination with foam. Sometimes a laser can be done for the paratibial and posterior tibial perforators. Sometimes we do that because the calf muscle pump tends to keep these perforators open longer. However, that's the only ones you should ever do a laser on. You should never laser a perforator in the posterior calf, or it doesn't work in the thigh. Foam works 100% in the thigh. This is the popliteal perforator. You see a huge one. And you look at this and you think, oh my God, look, I got to inject foam there, it's going to go in the popliteal vein. Well, it really doesn't. And this patient was treated with the first exit of the varice. We injected foam into the first varice, filled up the popliteal perforator, and this is what the patient looked like about a week later. You can see it's all clotted. And it's going to stay clotted. It's a foam sclerotherapy, and perforators, except for the calf muscle pump influence, is 100% almost the first try. If you have calf muscle pump, then sometimes it's a little harder and may have to take another injection. This is lipodermal sclerosis or stasis. You can see here, this is isolated, caused by this one perforator right here, coccus perforator. Again, foam it. Now this may be harder, the posterior tibial perforators may be a little bit more harder to close. It may take another injection. You could also try a laser, this. I don't have any experience with the RF catheter. Venous ulcers. This is 8 weeks after percutaneous foam injection, which I think is a very important technique to learn. We published this in the Journal of Wound Care, and also it's come out in VASA last month. It's an excellent technique, and if you don't have a visible vessel to inject, you can always do ultrasound-guided injection. But you really think about it, what causes a venous ulcer? It's venous hypertension. If you relieve the venous hypertension acutely, you get a much better result. And so that's the whole purpose of this, is deliver foam sclerotherapy and clot the venous tributaries in the ulcer bed. Immediately, once that happens, ambulatory venous pressure is reduced, healing is accelerated. Patients usually respond with decreased pain in about 2 to 3 days after doing this. 80% of ulcers heal within 4 to 6 weeks, especially if they're superficial. If they're deep, it may take a little longer, but they do heal. Conclusion is that the essential component of any treatment is successful alleviation of venous hypertension. This pertains to vessels that are intra and extrafascial. You must treat both the cause and the result of pathology to get good results. Foam sclerotherapy is the most essential ingredient in treating venous disease. If you do not use foam sclerotherapy, then you should start using it, because you can't treat most diseases without it. Thank you. Right, so we're going to do a pre-recorded case right here real quick. And Dr. Thorpe's going to present this real quick for us. Who is? Oh, okay, I'm sorry. Oh, I'm sorry. Hi, how are you? Please go ahead.
You got the case? Up? I love the intro. They have this every time. It's like Rocky running up the stairs. Just so you can have the visual.
do now is a show you perforator ablation. So there's a refluxing perforator. A young lady who had various abscess vein, a lot of reflux, treated that, doing a lot better. Her pain, swelling has significantly decreased, but we're seeing that there's still some veins, there's some residual disease, and we can see a large perforator that's feeding an entire network of veins. Some folks like to just sclerose that with foam, but I don't like to do that because the foam goes into the deep system. So we'll do an ablation of that segment just at the fascia, which we'll look on the ultrasound in a minute. So I'm doing the ultrasound now, and you can see on the screen in a moment where I find the perforator, and there it's leaking into the large branch, and that branch obviously goes up and is feeding into a whole bunch of other veins, that varicosities and reticular veins. So I'm going to come back and then take care of that perforator. So it's very important to identify where the fascia is and where exactly that perforator is feeding in. And I can see the fascia right there, and that's where we're going to go in with the ablation. So I've adjusted my probe position so that the vein is at the edge of my screen. As you look up on the screen now, you'll see that there's the fascia, there's the perforator coming in, and I will now position my needle in such a way that it goes right into that fascia. So this is how it will be once it's inside, along that's the angle, that's the pathway, and if you look at the screen, or the ultrasound screen, you'll see what I'm talking about and how I want to position that, and that's how I'm going to go in that direction. Yeah. So I'm giving lidocaine a little distance away so that I can get into that frame. And if you look at the screen on top, you'll see where the ultrasound, the lidocaine is coming in. And that's where I'm going to bring in my fiber from that angle. So with that angle now, I'm going to go in. If you look at the screen, you'll see I'm now basically spearing that portion. And the reason I know I'm in the perforator is when I look at the machine below, you'll see that the impedance is in the 280 range there. And that's when I know that the impedance is low. If I'm outside, the impedance would definitely be much higher. So oftentimes I should get heme coming right back, but I may not. And that just means that I have something at the tip of the needle, but as long as the impedance is good, I know I'm in good shape. And if you look on the screen, you'll see that my needle tip is right at the fascia, and the heating element is right at the level of the fascia where I'm moving the tip of my fiber. So I'm going to give a little lidocaine now right around the spot. And so now if you look at the screen, you'll see I'm giving the lidocaine right around the tip where the filament is and where I'm going to do the actual heating. Alrighty. And one of the things that happens if you look at the RF generator below is as soon as I give that, the impedance drops further. And I know that I got adequate anesthesia around it. The assistant then presses on the RF power button. She keeps it on there. In case the patient feels something, stop it right away. So far nothing, because that is a good 83.6 degrees centigrade. If she felt it, she'd either hit me or tell me, one of the two, but definitely at least scream a little bit. And so far so good. The assistant takes a finger off that. It will go up to 4 minutes. And if for any reason this is in the wrong spot, as in not still within the blood vessel. The impedance goes up and the machine stops by itself. So you'll see as the seconds go on, the impedance has stayed in that range. And we'll go back and look at the ultrasound screen, and you can see the location where the heat is being applied, and it's right in the spot where I want it to be. So you can see we're now at just about 2 minutes, and if you go up to the ultrasound monitor, we'll see we're in the same spot and that is still continuing to apply the heat, but you can see the coagulum around it and the echogenicity. If I pull this back or it's in major tissue, the impedance would go up and the machine would stop on its own. I do this at 4 up to about 4 minutes. Occasionally, if there are branches around it, I'll foam them at the same time, but not today. We'll just ablate this for now. So as you see, we're starting to reach just around 4 minutes here. And if you look at the ultrasound now, you'll see that the branch that we had before is definitely not visualized anymore. That's heated up completely, and we just stopped the generator at 4. If I pull this back, you'll see that the impedance will rise dramatically. Can you show that, please? And you can see the impedance goes up, and when that happens, the machine stops automatically. So, and now I'm taking that out. If you're on the skin, you'll notice there's no significant bleeding of any kind. There's just the one nick from that site. And I'm looking to make sure, and if you go back to the ultrasound screen, you'll see that that particular branch is completely occluded and there's no flow within it at all. So as you saw, if you have the right angle and the right approach, this can be very straightforward. What you don't want to do is go too deep or, for that matter, too superficial. And it's a relatively straightforward and simple procedure if you have it identified well.
Excellent, excellent video. I mean, it's, how nice is that? And I'm sorry we got out of sequence. I apologize for that. I have 2 questions.
Yes, please.
Exactly what length of that did you treat with the RF catheter, and also what is your success rate in the patients you've done, just with not foamed, but just with the RF?
So we definitely make sure first that the size is 3.5 large, refluxing, and standing ultrasound. It's when we put them supine, you always see a change in the size. If properly done, they're 95+% success rate. But I rarely, this was one of the few cases I did without foam. I was very excited to hear your talk because I'm a huge user of foam. And what I do is combine therapy. I ablate right at the fascia. I've had one case where there was a lot of foam went in and he got DVT. It was unexpected. Since then, I use this as a plug right at the fascia and foam all the tributaries outside. I actually do them both at the same time. And the success rate would be 95+%. Did you have another question? Did I forget something else? No.
Yeah, what is the length that's actually treated of the perforator?
Depending on the size of the perforator. In this case, it's taking a U-turn. I just want to be at the fascia. I don't want to be deep. I just by trial and error learned that not to be deep. I noticed in your talk you had mentioned not to go anywhere near the posterior tibial ones, but I've even done some at the ankle, but very carefully right above at the fascia or above. But I'm doing about a centimeter max, maybe less.
Are there any other questions or comments?
Do you always just use lidocaine, or do you use tumescent?
Just lidocaine's enough because it's just a spot. And you really, tumescent is when you need to fill the whole area. It came from plastic surgery where you were going to do liposuction. We don't have that necessity here. So lidocaine's just enough. You put too much, it obscures things, it moves, it's a bit of a problem.
So you ablate, excuse me, that you ablate the perforator, but you foam the varicosity near the perforator?
Well, the minute you ablate the perforator, there'll definitely be some amount of spasm. So this lady first came to us with the venous ulcer, healed, and now there was a residual perforator. We wanted to treat it, so there's chance of recurrence is extremely low. So what I usually do is I get into the perforator, add the fascia, get ready to start, but don't start heating. I get a butterfly into a large branch, tributary, wherever, and while I'm heating, I start putting some foam. I know that foam's not going to go into the deep circulation, and I let it kind of sit in the tributary. As Dr. Bush said earlier, the secret of this is get rid of the venous hypertension, improve the ambulatory venous pressure. That's the secret, that's the magic. Did I answer your question? Did that make sense to you?
Well, if you don't use thermal ablation, then do you just inject the varicosities near the perforator?
Yes, but the problem with that sometimes is there can be quite a bit of flow back and forth. And one, the foam's flown away. Two, is you end the deep circulation. Three, I see patients with big venous ulcers and a lot, 5, 6 big perforators. You just put foam in there, the foam is just flowing all over the place, and that's like firing bullets anywhere, so it's like spraying bullets. So I'm usually nervous about that. So I'd like to plug the hole where the leak is coming from. That's what I do with the perforator.
Or you can just inject the venous ulcer bed with a small butterfly needle, and you'll get the same results. You maybe get a reoccurrence if you don't treat the perforator, but you can get good healing rates by just acutely occluding the ulcer bed. That's how that patient I showed you, we actually injected her perforator with foam, came back, and ulcer was healed, and the perforator was wide open. That's our first indication, 2006, that you need just to foam the ulcer bed. And so all of our patients since then had ulcer bed foamed and anything done later.
Worth a try.
One more question.
So in our clinic, I was taught to do 3 different angles when I do the perforator, but I saw you demonstrating just one time and 4 minutes, but my attending told me to do like 3 different angles when we were there.
So the concept is, let's say you've got a 5 millimeter vein and you put a needle in it and there's a heating element. So you want the heating element to touch the 4 sides. Personally, when you put all that lidocaine around it, it just compresses it. So if you move it, it's already kind of wrapped around the needle. So I don't do that. You saw I don't do that anymore. And I've done hundreds of these, lots and lots of patients. And fell into this in the sense that I had all these patients from wound care, and we had to fix them GSV, but they still tried some injection, not working. So I started knocking off these perforators one by one, and the wound care just kept sending more and more patients, and I knew something was working. And initially when I used to use lasers, but they're not FDA approved for it. They are approved for just short segments, so there's some Medicare reimbursement issues and other things. So I started doing RF. And when they first taught me, per the IFU, you're supposed to go full quadrant. But it didn't make sense to me because it's wrapped around it. So what full quadrants am I touching? So you don't need it.
Okay, thank you.
Very nice. Our next discussion is going to be by Dr. Davis, is going to talk about avoiding the pitfalls when treating superficial venous reflux. Dr. Davis.
Thank you very much. I purposely left on the title there, the expert portion of it, because I really don't consider myself a true expert at this, but I've learned a lot as we've gone along doing these things, and I think I can give you my pitfalls and certainly some guidance on what to do. Those are my disclosures. I put this up, and I just want to give a little story on how I think venous ablation is going about now in this country. I think a lot of people are learning it. The volumes are going up tremendously, and I see cardiologists like myself wanting to get into this. And how people are doing it is they're going to watch 5, 10 cases, and lo and behold, they're putting catheters in people and ablating veins. And you really, truly do need to learn more about this and learn how to do this. For those people in the audience who want to get into veins or have started to get into veins, I encourage you, and I'm glad you're here because I think that you have to learn exactly what's going on. If you look at legal claims for these, I was stunned when I saw venous varicose vein claims being 58% and arterial 41%. And if you look at the top number there, it's nerve damage. And it's not an uncommon thing, especially if you start, when you start doing these things, if you don't really know where the nerves are comparatively what vein you're doing, you're going to have a problem. But you can see some other things there too. Unsatisfactory surgery, sclerotherapy, discoloration, scarring, femoral nerve injury, infection, femoral artery injury, deep vein thrombosis, tourniquet injury. There's a lot of things that go on here, and you really have to know more about this. So my top 5 pitfalls that I look at here and that I've come across and that I've learned to avoid as I've gone on are certainly these 5. The greater saphenous nerve injury, sural nerve and tibial nerve injuries, distance from the junction, protect the skin and tumescence, and non-saphenous reflux. So this is the great saphenous nerve location. And if you look at this, it covers the sensory nerve to the medial and calf, ankle, and foot. And you can see how close that runs to the greater saphenous vein. And again, if you look at the proximity of it in the mid-calf area here, you can see the vein from that arrow, or the nerve from the arrow there is very close in that proximity to that vein. So anytime you're treating someone in below the knee, you have, and there's a lot of variation on where these things come in proximity with there. So when you're treating, and I think in terms of the simpler C1, C2 vessels that patients that you're treating, I think those are the ones that you really got to be cautious going below the knee. I think the ones above the knee are certainly much safer in that degree. But the more important thing, if you're treating wounds, the C5, C6, I think you really have to get proper informed consent to that patient, because those patients, a lot of times, they will have some nerve injury or nerve damage. And so you really got to caution them, and you really got to go tell them that, because they're not going to be happy afterwards, even if they have a healed wound. To the sural nerve, distal short saphenous vein. The sural nerve is the most frequently used sensory nerve for transplantations. It's considered mostly sensory, but it does have some fibers. Neuropathy following vein ablation has been said to be 4.4%. I think for true experts and knowing how to avoid this, it's probably lower. For the non-experts, it's got to be much, much higher. You can again see where the sural nerve comes in across here. It covers the sensory for the lateral portion there and goes down to the ankle. And again, there's a close proximity of that nerve right to the vein. And again, that's the important aspect. You really have to know where that is. And it's not always at the same spot. There's going to be a considerable variation where the proximity of that nerve to that vein is that you're going to be treating. So know where your zones of proximity are. And you can identify these nerves sometimes by ultrasound. But without identification, I think this is sort of a good tip in terms of where you're going to be doing this. If you're doing you want to stay 18 centimeters above the medial malleolus for the greater saphenous vein, and 26 centimeters above the floor for the short saphenous vein. But if you look at that, that's going to get you're going to stay away from majority of the close proximities of those nerves. And you'll probably stay away from nerve palsies from that, or nerve damage from there where they'll have neuropathies. But again, there's a considerable variance on that degree. And so you have to know that, identifying it, and really be careful where you're looking at those nerves. Tibial nerve sits on the popliteal vein typically, as you can see here. In the red, you can see the small saphenous vein coming into the popliteal vein and the tibial nerve running on top of there. It sits very, very close in proximity. The SPJ junction is very close. And you can see that fascial curve there where it comes down into that popliteal vein. So you really have to be careful in that junction there to avoid actually putting your catheter in there and ablating that area. And again, be mindful, there's a lot of variations in terms of the anatomy of the gastroc vein and the popliteal vein and where everything comes in there. So you really have to know that anatomy and be careful where you're putting your catheter, because if you don't really recognize that, you can easily cause damage to that nerve. Avoid avoidance of endovenous heat-induced thrombus is my third pitfall here. And again, you can see here this is the saphenous femoral junction. at that point. Where it comes in there, when you're measuring it, you got to be careful where you're measuring, because you can see exactly what I'm talking about here. We always talk about 2 centimeters from that junction, but that 2 centimeters can be varied depending upon how you're measuring it. And I think the further back you get, obviously the safer you're going to be, but you may miss some areas where you may have to ablate. So you really have to be cautious where you're measuring that distance from the junction. So 2 to 3 centimeters distance is important, but again, look at the junction at there, and you can see the variance there. And when you're ablating these veins and you look at the under ultrasound how it's going, you can see that thrombus being propagated, the heat being propagated forward. So again, be cautious in terms of where you're actually measuring that offset, because it can really make a difference in where you're going. Tumescence for perivenous anesthesia. I think this is a very important aspect of it. You have to be knowledgeable of what you're doing, because again, it's not just the pain of the patients, but again, what you're going to be doing is you're going to be putting enough tumescence around in a halo effect, and I think that's very important, especially getting that posterior fascial area there, because what you can do is you can push those nerves and away with that tumescence as well too, and avoid injury from those that degree. So tumescence, putting it in a circumferential area such as this, I think is extremely important. You can avoid skin damage from it, because again, you want to be at least 1 or 2 centimeters away from the skin. You want to make sure that tumescence comes down there in terms of that as well too. So it really will help if you use adequate tumescence, especially in those junctions where the saphenous femoral junction up there, where you can have the nerve damage, and especially when the short saphenous vein, when you come into that curve area there, enough tumescence can really push away the nerve structures where you can have less problems there. And I think number 5 is the prevalence of saphenous and non-saphenous tributary reflux. One of the worst things you can do is sit there and have a patient, you've ablated the vein, and they still don't really feel that much better. They haven't really done much. And we've seen some tributary vessels here being treated, just this last case here in that degree. So if you look at it, 80-85% of the patients are going to have greater saphenous vein and short saphenous vein issues as causing their problems. But there's going to be non-saphenous vein problems as well too. And so should you treat these patients, you really have to decide and define which patients you're going to treat. Because if you treat the wrong patients or do the wrong thing to that patient, again, you're going to have an unhappy patient who's went through a procedure and really has not gotten a good, successful result. So in summary, nerve injury, know your anatomy, and tumescence use. It's important. It'll help you in that degree. You have to become an expert at doing these. Nerve injury, you can't treat it, and in many cases it's permanent. DVT can be treated, but it can be avoided by good technique and measuring where you're at. And then you really have to know proper patient selection, who has actually truly saphenous vein reflux, and where that saphenous vein reflux really actually is to treat it. Thank you.
Thank you very much. We're going to go right on into the next one, Dr. George. He's going to talk to us about the insurance company's favorite topic that we have to deal with when we try to get certification.
All right, good morning. I'll try to keep it short and sweet. I know we're running behind on time. So my topic today is compression therapy. And I think the exact topic was controversies in post-procedural and pre-procedural compression therapy. I could be really quick and just tell you there are no controversies and be done, but I will quickly go through some of these salient topics. My disclosures, I will tell you that I wear Ames Walker compression stockings, and I'll tell you, for those of you, a lot of you that are on your feet a lot and spend most of your day standing, that you probably would need compression stockings at some point. And I've treated a lot of the patients in my cath lab just from development of venous hypertension and varicosities. So looking at conservative management for patients with chronic venous insufficiency, the first treatment is leg elevation. We say toes above the nose. So if you can elevate your legs, decrease that hydrostatic pressure within the venous system, that helps drain the veins and get the blood flowing back up to the heart, and therefore it reduces the pressure in the venous system. Obviously, we talked about the leg exercises and using your calf pump. Moving your calves actually squeezes these veins and empties the blood from the venous system in the lower legs, and so that's critical. And we know that a lot of people that travel a lot now, it's become a mainstay of the instructions on the airplane even to do these feet exercises as you're on the plane in the seated position. Compression stockings is next. So this is obviously just manual compression. As you squeeze your legs, you decrease the pressure within that venous system and encourage flow against gravity up towards the heart. And then obviously medication. So I'm going to focus on compression therapy. So what does compression therapy actually do? It increases, what's increased is the tissue pressure and the venous velocity. You're trying to shift blood from the extravascular space into the central compartments to improve venous return. What's decreased is edema, soft tissue edema essentially. Your venous volume you're trying to reduce, and the reflux you're trying to reduce, although the effect on the valve is minimal. And by that you improve your venous pump, your microcirculation, and as we talked about earlier, it also improves lymphatic drainage. There's no good effective way of improving that lymphatic return other than manual compression. So graduated compression stockings is what we recommend. By graduated, you mean that there's a gradation of pressures through the level of the stockings. It's strongest at the lowest level where the hydrostatic pressure is the greatest, and that's at the ankle, and the pressure decreases in the proximal direction. So the pressure ranges are measured by determining the force that is necessary to stretch the ankle part of the stocking in transverse direction. So that's what graduated stockings are. As far as compression class, this is very important to know, especially with third-party payers and being very specific about what kind of compression is required before more invasive therapy is reimbursed. So a class 1 compression is 15 to 20 millimeters of mercury of graduated compression. That's considered moderate compression. Class 2 is 20 to 30 millimeters of mercury and firm. Class 3 and 4 are much stronger. With class 4, you're looking at 40 plus millimeters of mercury, and that gets extremely painful and more difficult. And as they become more difficult for the patients, compliance decreases as well. So class 2 is what's typically required pre-procedural therapy, and failure to resolve symptoms with class 2 compressions is what allows further invasive therapy. Compression therapy by SVS and the American Venous Forum guidelines is not the primary treatment of symptomatic varicose veins in patients who are candidates for venous ablation. So that's a grade 1B recommendation by the committee. So the contraindications, and this is where controversies may come in. It may include arterial insufficiency of the severe kind, and a lot of us are involved in treatment of arterial insufficiency as well, and so it may require you to treat the arterial side before you treat the venous side with compression. Cutaneous infections, hypodermatitis in an acute setting, wet dermatices, non-ambulatory uses, so if the patient is non-ambulatory, obviously that's going to make it difficult. Diabetic microangiopathy and neuropathies and congestive heart failure. These may or may not be absolute contraindications, and the reason why congestive heart failure is listed is really only because that's going to increase the venous return, and in a patient that's in stage 4 heart failure may be exacerbated with adequate compression. Patient compliance, obviously proper fitting is important, education and reinforcement that this is important for their care, and there are devices that have been made now and sold to aid in the application of stockings, so even to put stockings on, there are aids that are available. We heard earlier about some of these automated compressions that are available that are comfortable for patients, more comfortable, but they can be expensive. And unfortunately, insurance companies will not cover a lot of these procedures without documenting conservative management. So we do have some studies that show marked improvement in symptoms, and that's with 70% compliance. So I think the geography where you come from is going to make a difference as well. Here in the Windy City, in winter months when it's really cold, your compliance is probably better as opposed to Texas in the summer where it's 100+ degrees. It makes it extremely difficult for patients to be compliant with this. But we know that there is improvement in pain and swelling, in skin pigmentation, activity, and just overall well-being in patients with compliance of compression stockings. I will quickly go over a case where there may be some controversies. This is an 80-year-old female that I treated with history of chronic kidney disease, ischemic cardiomyopathy, had a peripheral arterial disease, came in with a left foot ulcer. And this is the reason why I went into starting veins. I started off on the arterial side, and then we saw a lot of these patients that came in with ulcerations that were non-healing and already had multiple arterial interventions done. This patient was taken care of by someone else before I came into the picture. On the initial exam that was listed, the patient had non-palpable pulses, had a Doppler signal of the left DP, a medial malleolus ulcer with some erythema and edema, and no tenderness to palpation at all. Had an AB of 0.43 in the left lower extremity. Had multiple interventions done. The initial angiogram on the left side, if you're used to looking at arterial angiograms, shows you an SFA occlusion, and then reconstitution of the distal infrapopliteal segment that was nicely revascularized by this previous physician, stented in the SFA, got great runoff, but guess what? It didn't heal. The patient came back again, had further interventions done in the below knee segment, had some atherectomy done, balloon angioplasty done, had a drug-eluting stent done. Ulcer never healed. Patient came to me for a second opinion, and now I have a picture of the ulcer, and you can look at it, and that's classic gator region for a venous ulcer, and right away flags went up. Could this be a venous ulcer? There's a prior history of arterial interventions, but let's get an ultrasound. Had severe reflux in the GSV, had a severe reflux in the SSV, had an incompetent perforator, and I ended up doing all three over a course of about a month. Did the GSV ablation, RF, did the SSV ablation with RF and a perforator, the ankle perforator right under that ulcer with the RF stylet. So that was over 1 month, and 1 month later I saw her in follow-up, completely closed GSV, and the ulcer had completely healed or had come close to healing. And now, having said this, I will tell you that before this, there was compression therapy involved, there was compression therapy after, there was wound care involved. So it takes a variety of different aspects of taking care of this patient to completely heal the wound. And with that, I'm running out of time, so I'll just stop. And if you have any questions, I'll take it at the end of the session. Thank you.
Our last presenter will be Dr. Traval. Is going to talk about the comparison of RF and laser for thermal ablation.
So I was asked to look into the recovery study. So what I decided to do is to look at the study and compare it with other randomized controlled trials comparing radio frequency and laser ablation. So let's look at the recovery studies, randomized controlled trial number 1. It was published at the Journal of Vascular Interventional Radiology in 2009, performed by Almeida et al. It was a multi-center trial with 5 centers in the US and 1 in Europe. And he compared the closure fast versus the diode 980. And the outcomes was a follow-up at 48 hours, 1 week, 2 weeks. They had 69 patients randomized, and they were looking at pain, ecchymosis, tenderness, and quality of life using the Venous Clinical Severity Score. So I'll tell you about the second study, which comes from England, Charing Cross and Imperial College in London. It was Shepard et al. Is a group of Davis. I don't know if you go to Charing Cross at all, but he's very famous over there. They compared the closure fast and the diet, same study basically. They look at 131 patients, and the follow-up was at 3 days, 10 days, and 6 weeks. And they mainly focus on looking at pain, analgesic use, and quality of life changes. So the third study, it's my alma mater, the Jones Vascular Center, published in the Journal of Vascular Surgery, Gale et al., single center RFA catheter versus the EVLA diode 810. It was, they had follow-up at 1 week, at a month, and at a year, and they had about 120-some patients and 141 limbs. So they measured bruising, recanalization at a year, and quality of life changes using the CVC and the VCSS. The fourth trial, it's from Greenhall, it's in England as well, and they did compare the closure fast and the EVLA diode 810. The follow-up was at a week, at 3 months, and they randomized 159 patients. So let's look at the results. This study measured their outcomes of bruising, pain, and recanalization. So looking at the results, we start with the recovery trial, right? They said that pain was significantly better, ecchymosis and tenderness at 48 hours, at 1 week, and 2 weeks, okay? He also went on and said that quality of life was better at 48 hours, 1 week, and 2 weeks. And they had just minor complications, and in that also RFA was superior to laser. So in all their outcomes, the recovery study said that their outcomes for the radio frequency was superior to laser. They did not measure recanalization. Okay, so in red, what we see is things that are not consistent with the other studies. So the second study, they said also pain, right, at 3 days and 10 days was superior with the RF than the laser. They had less pain. Analgesic use was statistically significant, and it carries on to be more significant at 10 days. Okay, with the quality of life, they used the Aberdeen, the VCSS, and the SF12, and they were very thorough evaluating this at 6 weeks, and they see no difference. At the Jones Vascular Center, they did say that the bruising was much less at 1 week with the RF catheter, but there was no difference at a month. The recanalization was superior on the laser, as RF had more recanalization at a year. And the quality of life, it's weird because they said that it was superior at 1 week, but there was no difference at a month. And there was no difference at a year. So our fourth study, they had bruising and pain, putting that RFA was better at a week. They did not measure it further on, and they said that recanalization was no difference from either or at 1 week or at 3 months. So to make it simple, in conclusion, we can say that the recovery study with regards of pain, bruising, and tenderness appeared to be consistent with other randomized controlled trials. But when you look at the recovery study with regards of quality of life, it's appeared to be slightly inconsistent with other trials that say that one says that the laser is better and the others showed no difference with the same time frames that they did. So, you know, there's a little bit of disagreement. I don't think if this is really important with regards of the quality of life. I don't think that the quality of life at 1 week will make a big difference on the outcome of the patient later on. What I do suggest is that if you are very comfortable with the RF, use the RF. If you're very comfortable with the laser, use the laser. And like Dr. Bush says, if you're comfortable with MOCA or doing sclerotherapy and his technique is good for him, I think you should stay with what you are comfortable with and gives you good results. Thank you.
Thank you very much. We're going to take a break and come back at 11:02. Just one final thing. There's a journal called Vein and Lymphatics that's published online out of Italy. It's an excellent journal. It's free, which I think is nice because we doctors have to pay for medical knowledge. When we provide it, I think it's kind of silly.
Quick question.
Yeah, one question, I guess. Yeah.
This goes to Dr. George. In your case, you had mentioned that the patient you had prior arterial interventions and still had that live ulcer, which was not healing. You also did mention that the ABI was like 0.43 before the patient came to you, and you ended up using stockings before and after. The question I have is there an absolute number or range of ABIs in which you will not use compression stockings?
Yeah, so this patient's ABI had improved to 0.9 after that SFA intervention. So I felt quite comfortable using compression stockings at that point. As far as a hard number, I don't have a hard number. I gauge it based on the patient. In this case, it was quite obvious that it was related to a venous ulcer. And sometimes you can use localized compression just to reduce the fluid buildup around the ulcer. You can use even an ACE wrap right around the wound to try to compress just that area. So it depends on the overall function. If it's 0.4, you obviously don't want to use compression stockings. But if it's 0.6, 0.7, 0.8, that's probably a gray area. Greater than 0.8 is you can feel quite confident.
All right, thanks.
Very nice presentation. I like that video.
How's that look? Hey, I've got.
What about Argentina yesterday?
Did that make it just so much worse for you?
Yeah, a lot. You know, my last name comes from Germany, so I'm a German guy. Okay. Well, that's true. That's true. My family comes from Germany, so. That's great. That's great. Right now in Brazil we have 160 million Germans.
How many Austrians?
No, I mean they're all German.
Right.
German. Only German.
Of course. Yeah. Not offhand, although I mean it wouldn't be hard to get on Google and find one.
Oh, Google.
I mean personally that's what I would do because I don't have it.
No, I know. No.